Greetings, this is Alan Lewis, and welcome to the fourth lecture of the School of Health Professions Dean's Lecture Series on Culture. Today we're going to talk about cultural competency, cultural efficacy, and cultural humility. These three concepts really address how healthcare providers are supposed to provide services across cultural lines effectively. So they embrace the strategies that individuals need to use as healthcare providers to ensure that the services are sensitive to people of different cultural backgrounds and efficacious. So cultural competency, at least from the counseling literature, which is my background, first began to really be visible around 1992. There was a seminal publication that was done by Sue Arredondo and McDavis in 1992 that really did bring things to a focal point in terms of the need for the counseling professions to do a better job with cultural competency. Both cultural humility and cultural efficacy came later. Cultural humility came in 1998, and it was promoted by Tervalon, Morey, and Garcia. And then cultural efficacy came in the year 2000. A clinician, a physician actually by the name of Ana Nunez promoted that concept. So both of these concepts are important concepts. However, neither one of these concepts utilizes what I call the expert or key recipe or key prescription approach when it comes to working across cultural lines. If you look at a lot of cross-cultural counseling books or cross-cultural health services books, a lot of them take the approach of outlining the key knowledge that the authors believe you have to know in order to work successfully with persons who are in particular cultural groups. For example, they'll say, these are the cautions, these are the tips, these are the hints that you need to be aware of if you're working with persons from Latino backgrounds or Asian backgrounds or Native American backgrounds or African American backgrounds. And I don't subscribe to that approach because there are two problems with that approach. First of all, there is no key recipe prescription that always works when working across cultural lines. Because for one thing, it's impossible to be an expert on any one cultural orientation. There is no one who is truly expert on a given cultural orientation. So it's impossible for anyone to write up a set of guidelines that would be a recipe or prescription for how you work with that group. The other issue is that people who are within a culture are still very heterogeneous. So there is no homogeneity within a cultural orientation. There's a lot of within group variation. And even with that within group variation, there's a lot of differences in terms of the degrees to which people actually identify with being a member of the group, based on how acculturated they may be or how assimilated they may be in terms of their own orientation. So it's far better to not use that information that speaks to the key recipe or prescription for how you work with folks, unless you're ever in a situation where you absolutely have no ability to collect information from the healthcare service recipient, then you can use that information by default. But rarely would you be in a situation where you absolutely have no contact with the recipient of services. If you have contact with the recipient of services, then obviously you can ask that person some questions to really begin to understand her or his cultural orientation and how they identify with a particular cultural group. And that's far better because you're getting the expert information from that person as opposed to reading about it in a book, and it may not apply at all to that person. So I call that default information. The information that's in the books, that's the recipe or prescription, I call it default, which means when all else fails and you have absolutely no way to talk to the person, then you rely on that information because it'll give you a clue. But it may be just as much wrong as it is correct. So ultimately, you want to deal with the person who actually is in front of you, who's your service recipient, because that person can give you all the guidance you ever need about who they are in terms of their cultural orientation. So starting off with cultural competency, that's the oldest concept. So, well, before we do that, let me just say there are 5 assumptions that really speak to how cultural competency, cultural humility, and cultural efficacy can be effective. These can be very effective interventional approaches working cross-culturally, but you have to really embrace these 5 assumptions. So the first assumption is that relationship is key. I've said it before, most of us realize that the single most important aspect of a healthcare provider, a healthcare service recipient encounter is the strength of that relationship. because of that rapport, that relationship is strong, then of course the trust begins to build. And that's a very important aspect for the encounter to be viewed as having been successful by that service recipient. So the first one is relationships is key. The second one is realize that we're all cultural beings. Even though you may not really think of yourself very much along cultural lines, each of us has a cultural orientation. Each of us has multiple cultural orientations. We have a cultural identification orientation based on our professional life, our personal lives, and the many domains that we have in our personal lives. Also realize, number three, that who you are culturally, who any one of us is culturally, is always going to be very different from the person that you're providing services to. So we each have a different cultural orientation. Even though we all are cultural beings, every individual has a different cultural orientation. And therefore, there are potential points of collision between two individuals because they're two cultures, and those two cultures are not the same. So there always is the potential for some collision between the cultural orientation of you as a healthcare provider versus the cultural orientation of the healthcare service recipient that you're providing services to. Number four, each one of us has personal biases that can contraindicate working well with someone from a different culture. We had a segment on biases before, so you'll have to go back and review that, but each one of us has our biases or preferences, likes and dislikes that have the potential, at least, to contraindicate working with somebody cross-culturally, particularly if those biases, preferences, or differences are focused on cultural orientation. So they can certainly fly in the face of an effective encounter and an effective and efficacious service delivery process. And number five, the fifth assumption is that as a healthcare provider, we must be fully in touch with both our own cultural identity and our biases, and be able to mitigate whatever potential negative impact they could have on a service delivery encounter. So only when you know your cultural identification, your own cultural identification, only when you know your own biases, do you have the ability to put together a plan that contains them and mitigates their potential negative impact. So with those five assumptions in place, then cultural competency basically says that the healthcare provider really has the mission of finding ways to work with the service recipient in a manner that meets the service recipient's expectations of both the process, that is how the services are delivered, and the outcomes of the service delivery encounter. In other words, what's the bottom line impact? And that all must happen in a way that does not disrespect the cultural orientation of the service recipient. Again, cultural competency says that we have to provide services that meet the expectations of the service recipient in terms of the process, i.e. how the services are actually delivered, how the interventions are actually delivered, and what the outcomes of those services are, what the impact is. And those services have to also be delivered in a way that do not disrespect the cultural orientation of that person who's receiving those services. So cultural competency really is as simple as that. If you embrace those five assumptions and then do those few things, then you are able to provide culturally competent services across cultural lines in the healthcare environment. Now, cultural efficacy is similar to cultural competency. It's really the same concept, but the difference between cultural competency and cultural efficacy is that cultural efficacy says cultural competency makes the mistake of implying that to be competent is, in a sense, a destination, that a person can actually arrive at a point of being culturally competent. And once you've arrived at that destination, then there's no need to do anything more. Cultural efficacy says, no, that's not actually possible, that you would never arrive at a point of being culturally competent and working with somebody of a different culture. So it's always an ongoing, continuous improvement process of becoming culturally efficacious and becoming culturally aware of the person that you're working with. So cultural efficacy says that it's an ongoing process. It's not a destination. The other key thing that cultural efficacy says that's different from cultural competency is that cultural efficacy says that many times when people are trying to be culturally competent, though they may have good intentions, there is sort of an inherent hierarchy or pecking order. And so what they're saying is that people who are working using the old cultural competency framework oftentimes feel like the majority culture or the dominant culture is in some ways superior to these other cultures, and that to work effectively with somebody from a different culture means that they're basically is a comparison between the two cultures. And so the person from the dominant culture is basically working with this other different, quote unquote, less than culture. So that inherent hierarchy, one is better than the other, which is implicit in cultural competency, cultural efficacy says can't be the case. It says there's basic parity across all the cultures. They're all equally valued and relevant, and there is no inherent hierarchy. So again, the difference between cultural competency and cultural efficacy is that cultural efficacy says, no, you can never be totally competent. That's not a destination that you can arrive at. It's an ongoing process. It's a dynamic process that you always strive to get better at. And there is no inherent hierarchy among the cultures. All cultures are on the same level playing field, and there exists parity across those cultures. But the basic strategies are the same. Providing services that are delivered in a way that meet the client's expectations and meet the client's expectations in terms of outcomes or impact, and that do not disrespect that person's cultural orientation. Cultural humility, much like cultural efficacy, says that working cross-culturally requires the same strategies that it requires to be culturally competent, but that the person who is the service provider has to consciously and continuously adopt a position of humility and be humble about learning about the person's culture that they're providing services to. And again, takes that continuous quality improvement approach and says that it's an ongoing dynamic process. You never fully get to the point of being expert in that person's culture. You're always learning about it, but you're learning about it from a position of humility, being very humble about it. And so it's an ongoing process, and you're very humble as you're learning it. So basically, cultural competency, cultural efficacy, and cultural humility are very similar, except cultural humility says it's a very humble position that the healthcare provider has to take in their ongoing learning, which is a dynamic process. Cultural efficacy says it's that ongoing process of learning because you never reach a point of being competent, and there's parity across all cultures, that there's no inherent hierarchy that speaks to one culture being a little more dominant and more superior than another. So essentially, cultural humility and cultural efficacy are the same as cultural competency, but they're just newer generation updates to the concept. Again, providing culturally competent services really does require to embrace those three assumptions that relationship is key. We're all cultural beings. Who we are culturally as a provider is different from whoever we're providing services to, and then potential points of collision. We all have biases that we've got to manage, and that we all have to know our own identity and our biases to make sure that all that gets managed effectively. And then with that, if we can then provide services that are delivered in a way that meet the client's expectations, that meet about the delivery process, about the process of delivering and receiving those services. So the culturally competent provider has to meet the client's expectations about how the services are delivered and what the impact of those services is. So it's process and outcome. And then also has to provide services in a way that do not disrespect that person's cultural orientation. And then humility says, yes, but you got to do it from a position of humility, and it's an ongoing learning process. And efficacy says, well, it's definitely an ongoing learning process because there is no such thing as being culturally competent, because it's not a destination. It's always a continuous process, and that there's relative parity across all cultures. So pretty simple concepts, but difficult to embrace and make them work cross-culturally, because you've got to have a lot of knowledge of who you are and what your cultural orientation is and your biases, and you've got to embrace those assumptions, and that takes a fair amount of work. And then you've got to do the basic task of providing services in a way that meet the client's expectations and also meet their expectations in terms of outcome, and don't disrespect culture.